social media circles coming on with us. I believe we're going to have Stephen Poulter on with us in an upcoming episode. But those are going to be on our podcast, which we hopefully will start releasing soon once we have a few more videos under our belt. And yeah, that was pretty much it. Nothing super exciting in the infertility world. I will be presenting an article to you guys probably next week, I think, which talks about whether or not women with diminished ovarian reserve make worse embryos. This is a very controversial topic, and there is a new study. And so I'll share that study with you probably next week. I was going to do it tonight, but we had the chance to have Jessica on the show. So we went with Jess, and she's an amazing guest. So fire away with the questions.
So, you know what's a great feeling?
What's that?
When you're finally recognized by everybody. Unequivocally,
unequivocally and
fully acknowledged. So I want to thank everybody for this honor. It could never have been done without you guys. So thank you so much, Dr. Victory. This is a moment for you to savor as well. Allow me to ask the first question.
I don't want to take the drink.
Don't do it. Don't do it. Don't do it. I'm warning you. Don't do it.
Yeah.
You know, it's just a beautiful. As I scroll, I'm just in complete honor of all of you guys.
Yeah. By the way, I actually spoke to the patient today, and I said I would, mention her, who coined King Tea, and she was lovely and very deserving of better care than what she had received. And she was not getting good care, which was terrifying, from the clinic she was at. But she said, I'm the one that coined King Tea. And I was like, get out of town.
She's my new best friend.
She is your BFF.
Yeah, 100%. 100%. So first question starts very humble.
Yeah.
Hi, Kings.
Okay.
I did my first IVF when I was 38 years old.
Okay.
And 9 months on 2023. The protocol was 300 gonal F, 150 menopur, and dual trigger.
Okay.
I got 9 eggs, 2 mature, 1 immature, 5 empty zona, and 1 GV. It produced 1 live birth. We are planning to do another IVF cycle, and I'm now 41 years and 11 months. What would be a good protocol to give us the best chance for 1 live birth? Thank you very much.
I would probably be focusing on priming. So, I'd want to know your full history. I would want to know what medications you're on, your body mass index, your habits, your partner's habits, all the basics. But generally speaking, if your AMH is lowish, which I would anticipate it would be just based on the information you gave us, I'd be focusing on priming. So we use things like DHEA, testosterone, human growth hormone. Those are things we would consider. And then we would be using way lower doses because the dose you were on was too high. So probably like 150 gonal F, 150 menopur. And then on top of that, we would focus on doing, basically the double trigger and making sure that we probably retrieved you a little bit earlier than we would someone that is younger. And then doing a good ICSI, oocyte activation, all the little tricks we have in the lab to kind of maximize your outcomes. I see people every day who have gone to another clinic and they've been given the 300 and the 150 and they're frying all their eggs. And that's why you get that bad outcome. We don't want you doing those super high doses. It's great for making money because every clinic profits from the drug sales, but it's terrible for your well-being. It's horrible for your egg quality, and it just doesn't make sense. There's no benefit to using super high doses, proven over and over and over again in studies, and it's actually shown to be detrimental when you take those high dose studies. It affects the spindles in the eggs. It affects the DNA integrity. It affects even your microbiome, okay? So the microbiome of your uterus, which is preparing to accept the embryo, also gets damaged from high doses and high estrogen levels. You don't want to do that. You want to keep things steady, stable, easy, so that you have the best outcome possible. So don't take those super high doses. It's just a complete waste of money, and you're literally doing damage to your cycle. Take lower doses and get a better outcome. It'll happen every single time.
Hi, Dr. Victory and Dr. T.
Oh, there you go. Yeah, you're just getting all the love now, eh?
And I read this one
Yeah.
because this is kind of like okay now. Because if I read the rest of them to you, you'll know I've been elevated.
Okay.
What dose and drugs do you use for double trigger, HCG, and what else?
We use triptorelin, and we're using usually like 2 shots of the triptorelin. It comes in a pre-filled syringe. And then we're using HCG titrated to your estradiol level. So it depends on how high your estrogen is. You got a low estrogen, we'll give you a full dose. You have a, kind of medium-ish level of estrogen, we're going to give you like a medium HCG dose. You start getting high levels of estradiol, we're going to give you lower and lower levels of HCG so that we still get the benefits of the HCG, but we don't give you ovarian hyperstimulation syndrome. And knock wood, unless someone makes a mistake, we almost never get a hyperstimulation syndrome case. It's very, very rare, like one every 6-7 months, and almost always in an egg donor. So this is, how we would do it.
You ready?
Yeah, go ahead.
Hi, Dr. Victory.
That's me. Yeah, thanks.
And His Royal Majesty. Like I said, it's a build-up.
Royal Majesty.
Royal Majesty. Just so you know.
Now I know why you were smiling.
Yeah, it was a big smile today. As I was scrolling through the comments, guys,
just loving it.
My face could not hold back.
All right.
Do you ever use Paragon? What about Pergoveris? If so, in what situation would you use either?
Yeah, they're both good drugs. Like, we don't really have a tendency to say only use this drug or only use that drug. There is a case to be made for a mix of recombinant and urinary products. And I think that's worthwhile. And I think that that's, kind of an important thing for people to at least consider. But do I insist on it? No. Is Pergoveris a perfectly reasonable alternative choice? Yes, it's a great first line choice. It's a great alternative choice. Can you use Puragon? Puragon's a great product. We are using Puragon in some of our cycles. So I'm not a believer that like one company is better than the rest or one product is better than the rest. We have our protocols, we mix and match. Do I see a difference in the outcomes? Sometimes, but not always. And I think it's patient to patient specific. One of the things that I was actually talking about with patients during this talk I gave at the Canadian Fertility Show on the weekend was that we can now actually test for the type of FSH receptor you have. And based on the receptor, some people will do better with one product versus another. So this is something that's up and coming, and we're probably going to start working on so that people would just kind of send in their blood. We tell them, oh, you're better for the urinary product, you're better for the recombinant product, and we can tell them which one they're going to do better with.
Dr. Victory from TikTok. Your smile is contagious.
Thank you. I appreciate that. I do try and smile, especially when I'm listening to people talk. So I try that as much as I can.
Is there a way to determine the likelihood of normal embryos prior to receiving PGTA test results?
Is there a way of what?
To determine the likelihood of normal embryos prior to receiving PGTA test results.
There's AI software that looks at that. We use it here. It's called Life Whisperer. It will estimate or guesstimate based on AI what your chances of having a genetically normal embryo are. But keep in mind that this is purely a ranking system. So people get all scrambled with PGT. There's lawsuits against the PGT companies, all this anger. Oh, I didn't know it's, this and that. So the reality with PGT is you have to understand what PGT does. PGT essentially helps you rank embryos. We know now that a lot of this stuff we realized initially where we were tossing away embryos because they told us we couldn't use them simply wasn't true. I'll give you a brilliant example. You have a euploid embryo, it's euploid, you use it. You have a low-level mosaic, you can still use it as the same chance and outcome as a euploid embryo does. But if you have a high-level mosaic, should you toss it? No. Some high-level mosaics can have as high as a 35% chance of becoming a perfectly normal baby. What about a segmental aneuploid? A small piece of the embryo is deleted or added. 24% of those can become genetically normal babies. What about complex aneuploids? In our hands, we're finding that upwards of 50% of the ones we retested to see if they were normal or abnormal after we got a completely different facility telling us that they were abnormal have actually come back normal. So we're using some complex aneuploids in people. As long as people understand the risks and they go for this with whatever they want to do, it's perfectly fine to use all of these embryos. The only ones we aren't going to use are the ones that are like true, obvious whole chromosome aneuploids where it's one or two chromosomes that are missing or added. You're not going to use those because the chance of success is 0.7%. When you're looking at pre-selecting with these AI programs are essentially the same thing. It's going to help you rank the order of which embryos you use. It is not going to tell you diagnostically embryo 1 is normal, embryo 2 is not, embryo 3 is normal, embryo 4 is not. You're not getting that. You're going to get a percentage chance that the embryo could be normal, which just helps you decide, okay, maybe I should use number 2 before I use number 1, or I should use number 4 first and then number 2 and then number 3 and then number 1. You know, it's just going to rank the sequence of the embryos. That's all you're getting out of the AI, but it's very inexpensive compared to PGTA. And it can help people with that ranking system and guide you through the process so you have at least a little more reassurance than you would if you didn't do the PGT.
I have a varicocele with 50% motility. How much chance of success in IVF?
Well, that didn't tell me anything. You just told me you have a varicocele and 50% motility, but I don't know your count. I don't know your DNA fragmentation. I don't know your morphology, so I can't really answer that question. Plus, it doesn't just depend on you. It depends on your partner. How many eggs does she have? How high is her AMH? What is her age? What is your BMI, her BMI? Do either of you smoke, drink? I can't answer questions that require crystal balls, guys. Like, I wish this little, iPad was a crystal ball because then I could just consult that and then answer. But I can't answer questions that require a crystal ball. It's impossible.
I'm excited for my appointment next week, Dr. V.
Oh, good. I'll rant less during the appointment, unless you tell me you're doing the ERA test.
100%.
Oh, it was so hard not to talk about.
I saw that
because iGenomics was like right next to us, right? I'm like, oh, what do I say at the show? So I had to be on like my best behavior.
You were well behaved.
It was killing me.
I don't want twins.
Okay.
Do you offer fetal reduction?
I don't. You have to go to University of Toronto for that. I mean, I don't technically do it. If you wanted it done, I will send you to the doctors that do it. However, no one will tell you that it is recommended to reduce twins. We will always tell you to just leave that alone because you're risking losing the whole pregnancy. And twins is usually tolerable. Triplets, they also tell you it's up to you. You can reduce if you want or not reduce, but quadruplets and above, they'll tell you need to reduce. And in fact, they're now actually frequently telling people to stop the whole pregnancy because the outcomes are not good. And that's why the twins thing, they'll probably tell you not to reduce.
Does letrozole help with getting twins?
Help? You've got about a 5 to 6% chance of having twins when you use letrozole. So it's not for everybody, but it is usable. Should anyone be targeting getting twins? No, of course not. No one should be targeting getting twins. We know for a fact that there are 3 separate categories of risk when you're going for twins. Maternal risk, diabetes, high blood pressure, preeclampsia, bed rest, hospitalization, extreme amounts of back pain, belly pain, all sorts of leg pain, hip pain. Like, it's not a comfortable thing to go through. There are fetal risks. Twins come early. If they come very early, all of the prematurity risk, blindness, deafness, feeding difficulties, necrotizing enterocolitis, the lungs, respiratory distress syndrome, bronchopulmonary dysplasia, and then, of course, the worst stuff, all in the brain. You can end up with cerebral palsy. You can end up with, massive infarcts in the head, strokes, bleeds. These are disaster cases with terrible outcomes sometimes. And then even if everything goes perfectly fine and there are no problems and you sail through the pregnancy, the kids come out like, hey, mom, hey, dad, I love to be here. Thank you for, carrying me for 9 months. I'm so happy you guys brought us into the world. I got my high school diploma ready to go already. it's an 80% divorce rate. The guys just don't stay most of the time. They walk. And so, and I'm not trying to say anything about guys, that's pure statistics, but the relationships break down. So it's not a good thing to have twins. And so please never ask to have twins. The only time we ever support that is if the patient is genuinely a lot older. Then, like, I'm willing to put in 2 embryos. Otherwise, everybody should be getting a single embryo transfer. There's no benefit to doing 2 at a time. Cumulative success rates are the same versus 1, or 2 at a time for embryo transfers. And there's no reason to do it. You're just putting yourself and your babies at risk. Don't do it.
Dr. V, a question that you will love. You became famous for this question over the weekend.
Oh, God.
In your endometriosis FET protocol,
Yes.
what do you use to build the lining after 2 months of Lupron and Letrozole? Could the protocol be done without tacrolimus?
It could be done without tacrolimus, but you should use tacrolimus. That's probably one of the main reasons it works so well. And you don't need to use anything at all in many cases. But if you do need to use anything at all with the protocol, you use a very small dose of estrogen, 1 milligram, 2 milligrams a day. That's it.
Would you change anything in a frozen embryo transfer with endometriosis versus adenomyosis? I've had 5 failed embryo transfers and just been diagnosed with adenomyosis and a blocked fallopian tube.
Well, you should have your fallopian tube removed, so I'd change that. We don't do anything different between endo and adeno, but our endo-adeno protocol is what's being, kind of hailed as something that works so well. And it was great on the post because all these people started writing in and saying, I used it, I have twins now, I'm cradling my twins now, I used it, I'm 23 weeks now, which is what I hear like literally every day from people, right? So we know that this works. We see the reports. It's not even me putting it out there. Other people are reporting it. And it's a great way to go forward. It's a great way for us to see that we can help people and that people can get appropriate patient-specific care that they're not always getting. I spoke to a patient today, and she literally said that the doctor told her that the treatment for endometriosis was IVF.
Yeah.
I'm like, the treatment for endometriosis is not IVF. IVF makes endometriosis worse. It is not the treatment for endometriosis. Anyone that tells you that the treatment for IVF is endometriosis has absolutely zero clue what they're talking about. None. Zero. That is not the treatment for endo. The treatment for endo is an endo-specific protocol. You don't even necessarily have to do IVF if you have endometriosis. You can try natural. You can try IUI. You can try IVF. You can go for surgery. You have 4 separate choices, all of them equally valid. Sure, you're going to get a different success rate with different options, but there's absolutely no reason for a doctor to tell you that you have to do IVF because that somehow overcomes the endo. No, it doesn't overcome the endo. It makes it worse. And the best study on this, the one that just clearly defines it all and shows, categorically, unequivocally, that the idea that endo doesn't matter is absolutely false, is that when they take women who are getting egg donation, where the eggs are coming from patients that don't have endo, and they take the endo patients and they put the donor eggs in them versus the non-endo patients and they put donor eggs in them, the patients who have endo don't do as well. So these are patients where the eggs are never exposed to the endo until they get in the patient. And when they get in the patient, they don't do as well. It categorically shows you that the endometriosis has a negative impact. But no one's listening. They just keep selling patients this crazy story that endo doesn't matter. Endo matters. Endo absolutely matters. And if anyone tells you otherwise, go where they're not telling you that. Come see us or go see someone else where they're actually going to listen to you, because endo matters. You got to pay attention to it, and you need an appropriate protocol for endo.
2 months versus 3 months of suppression with Lupron Depot and Letrozole before FET for endosuppression.
Well, the studies have done both, and they've both shown a benefit. We tend to do 3 because that was the original study, but there is a follow-up study that did 2, and either one is acceptable. So whatever you want to do is good for you.
Hi, doctors. Any advice on supplements to help a thin lining? Haven't tried estrogen yet. Awaiting Asherman surgery before trying.
You're not going to thicken your lining if you have Asherman's because it's fused together. So I'm not sure I understand the question, but you would take things like baby aspirin, vitamin C, D, E, L-arginine has been shown to thicken the lining a little bit. Um, the rest of the things that work are not supplements per se; they're more drugs. Viagra can help, PRP can help. Neupogen can help, human growth hormone can help, obviously estrogen can help. But if your lining is stuck together, it's literally not able to thicken because it's fused together. So it's not going to open enough to be able to work. So in that circumstance, you just have to wait till you've had the Asherman's treatment.
Hi, King and Dr. V. Catch that? I'm 31.
I'm going to make you wear a crown next time.
I'm thinking
Napoleon's from the Louvre.
There we go. It's missing now.
Mm-hmm.
Maybe I have it. No one knows.
There you go.
There you go.
Yeah, where were you on Sunday morning?
Where was I Sunday morning?
Yeah, where were you?
That's it.
Yeah.
AMH 51.
51.
Woo! How many eggs should I expect from ER? Is PGT necessary or could we do Life Whisperer?
If your AMH is 51, we'd probably see like 25, 30 eggs if you were being gentle, more if you were being a little more aggressive. With that number of eggs, I would probably do PGTA on like 10. You'll have more than enough. I don't know what your age is, but you'd probably have enough with 10, and that should do the trick for you. So yeah, I would definitely be going for PGTA. Life Whisperer is fine, and it would definitely be way cheaper because it's not based on the number of embryos. But at the same time, I would be quite reluctant to do that as it doesn't make a ton of sense because you're not going to get the answers you want as far as which ones are genetically normal. Cool thing with Life Whisperer is that if you have two embryos in the very high category of genetics, so they have it broken down into low, medium, high, very high. So if you have two embryos that are in the very high category, there's a 97% chance that one of the two is normal, which is good. I mean, that's pretty robust data, but it only works if you have two in that category. So you could try it, but by the time you've locked in and done that, you've missed your opportunity to do the PGT. So I don't know that makes a lot of sense.
I'm going to fast forward a couple questions just to read it because I think this is a good one.
Sure.
They're all good. They're all good. Let me be correct. People, you guys are all great, obviously. It says Ferraris is 329 after infusion. Can this negatively impact my eggs? And then they
Ferraris?
mention, and then they say, sorry, Your Majesty, I meant ferritin.
Ferritin is what?
329 after infusion.
No, it's fine. Yeah.
Felt like reading that one. I liked it. The apology was to...
You're so funny. He's totally going to his head. I need to put a stop to the king.
Sure. Hi, Dr. V. Working with your clinic,
yeah,
my iron supplements are not working after several months now.
Okay.
Oh, that's interesting. Ferritin's at 29. Should I do iron infusion?
Yes.
What would you recommend? Thank you.
Yes, definitely do an iron infusion. Don't hesitate. Iron infusion all the way.
Hi, doctors. When do we get a follow-up appointment with you after an egg retrieval?
Once we see what your results are, and if you've done PGT, I call you to give you the PGT results. Otherwise, the nurses are in communication with you unless you need another cycle, in which case we get back on the phone with you again. But otherwise, we just get you ready for your FET.
Hey, I see you're feeling a little bit low. They got one for you. There's one right here for you.
I'm not low.
Don't worry, man. It's okay. It's okay. We know you're the real doctor. It's all right. Don't worry.
We're going to make Tarek wear scrubs from now on, everybody. Yeah, go ahead.
Royal King Tea.
Royal King Tea.
Thank you. Thank you.
Yeah.
And great Dr. V.
Oh, there you go.
There you go.
Yeah.
See? My people are good.
I
called your clinic today.
Yeah.
To book a remote consult to review Fertility results for remote TX plan.
Yeah. Treatment plan.
They said earliest appointment is February. Any way to get in sooner, like NP? I live in US, Florida.
Like NP?
Like Yeah, it says any way to get in sooner, like, and then capitals N, capital P. Like, no problem. Like now, perhaps.
Or maybe they mean with my NP, my nurse practitioner.
Oh, sure, maybe. You
Uh,
you would know better.
DM me and I'll see what the urgency is and we can go from there.
I'm just making sure they didn't correct it afterwards. Nope. Love this. See, people love
Excellent.
this. Of course.
What's happening on TikTok? Do we have any TikTok
Yeah,
questions?
I just put it down for a minute. I got to go through them all. You know what you're doing? You're fueling a rebellion right now.
I am. I'm feeling.
You're fueling the rebellion.
Yeah.
I am answering all the questions.
Yeah.
But here we go. What are the secrets for endo while having IVF treatments?
What are the secrets for endo while having IVF treatments? Nothing while you're doing the stim, just supplements and stuff like that. But for the transfer, we advocate for our protocol. It just works better. It addresses all of the endo concerns.
Oh man, there's so many. Somebody's asking if this video is live. Can you tell them?
This video is very live. Yes, this video is very, very live. We take live questions from around the world.
Okay, there's
actually, people think we're nuts.
Oh, really?
Oh, yeah.
You
all
hear
the
this?
time. Yeah. Other doctors are like, are you insane? But I do it all the time. Actually, and I'd love to get feedback from you. So I was on a panel with Prati Sharma, who is president of the CFAS, and Tom Hannum, who owns the Hannum Fertility Clinic in Toronto. And they were lovely colleagues on the panel, true experts. I have nothing but respect and admiration for them both. So thought came to me, why don't we have like more fertility factor fictions, but maybe with like a panel of doctors? And I kind of wanted to get a little feisty. Like I wanted to be a bit rowdy, talk to them in advance and say, listen, it's okay if we don't pull every punch, like be polite and respectful, but we can disagree a little more vocally. So interested in what you guys think, because there was one topic that came up about microbiome and immune, which I was questioned about at the meeting, and I gave my answer, but then they don't do that stuff. So they were like, no. And they gave an answer, and I wanted to keep the peace. So I didn't say anything negative in response, but I feel like that could have gone on a little more and we could have done more justice to that answer. So tell me what your thoughts are. Thumbs up if you think we should have like a group of doctors on this once in a while, like maybe once a month, and we rotate who's on there. And maybe I'm not even one of the ones talking. I could be like the moderator and ask them the questions and stuff. Give us your thoughts. Let us know if you think that's a good idea.
Can metformin help me lose weight?
Yeah, but not a lot. And in this day and age of GLP-1s, and apparently today I found out that Ozempic's going generic. So it's going to be like $200 a month cheaper very soon. So, I mean, it's affordable now, or hopefully will be. In that day and age, why would you go on something that has a little bit of assistance with weight loss, but actually is a nightmare on your stomach, when you could take something that has very little effect on your stomach and has tremendous effects on weight loss?
Thumbs up, thumbs up, thumbs up, fire. Yeah, that's a great idea. Group doctors, thumbs up, thumbs up, thumbs up, thumbs up. Only one, thumbs up, thumbs up, thumbs up, thumbs up. Thumbs up only if you promise to call them out with their bogus response.
See, that's the problem. I was up on stage. I'm like, oh, I can't say anything, right? Like, it's really hard. You got to be professional, and then you don't want to cut down your colleagues in public. And that's why I never, on this show, I will never cut down anyone. And we did have a bad stint where we did once upon a time cut down.
It was a different show. It wasn't this show.
Yeah.
It was a different show.
Yeah.
To be fair.
But we're not going to cut down any doctors. So, we're trying to keep the peace. And I don't want to cut down any colleagues, but, I don't mind cutting down stories or giving you my opinion, but I won't say anything else. Are you dying?
No.
Are you sure?
Just choked on air.
Just choked
on
air.
Choke. Air choke. It happens.
All right.
You said something funny, and so my whole body just decided to give up on me. The Famous Kings, TNV.
Oh, there you go. The Famous Kings. I like that.
That's pretty good, right?
Yeah.
Yeah, I read for that reason. Did I make the right decision by going against my doctor?
Oh. Bring it.
It already
I
sounds good,
love
to be
it.
honest,
Yeah,
right?
it's like,
Absolutely.
go for it.
Who suggested Vizan
Yeah.
before egg retrieval?
Yeah.
And only to do it before transfer Lupron, not Vizan. I have deep endo.
Well, actually, Vizan prior to egg retrieval has been proven to be beneficial. So you can do Vizan prior to egg retrieval. Now, the study that looked at it actually incorporated it in patients who were doing both fresh and frozen embryo transfers. But Vizan prior to egg retrieval is actually beneficial. However, Vizan prior to embryo transfer has never been studied. So we don't know if that works. Lupron alone prior to embryo transfer is useless. It has to be Lupron plus letrozole. Lupron alone doesn't do anything. So, I mean, your doctor was kind of partially right, but maybe not completely right, which is better than most because most doctors don't even pay attention at all. I think you and I have done more to change endometriosis treatment in North America than anybody.
I think based on just what you did on the weekend, you did more to change endometriosis than any doctor has ever done.
Like people literally were getting nothing. They were just getting, and there still are, like even as of today, they just keep getting endo doesn't matter. IVF is the treatment for endo. IVF is not the treatment. And so now people are actually asking and demanding something different, and the doctors are starting to. And now I keep hearing the same thing. Oh, now I'm on Lupron and letrozole. I'm like, that's my bloody protocol.
That's you. That's you.
Yeah.
Hey docs, do you know why in RE will note 5-6 follicles before trigger, but then end up with 20 eggs? Do more follicles pop up during the trigger?
No. Hell no. Now, they may not have seen them all. Some places don't measure well. Like they'll only measure the top size follicles, which are above a certain threshold. And then when you get to trigger, you realize there were more. The only other thing that like once in a while I'll experience is if the ovary is like rotated sort of sideways, some of it can get hidden. And so when you think there's only 5 or 6, you'll miss the fact that there were like way, way more. So that can happen, but it's really rare. We don't see that very often.
So would you call it bad counting, or is it a rare circumstance that happened to happen just now? We don't know who they are, so it's kind of free game here.
I don't know. I'd have to
see it.
Yeah, I'd have to see it.
You're a very fair man.
Yeah, I don't want to say because I don't know.
The king can say it.
The king can say whatever he wants.
That's right. No problem here.
As long as we're on like topics completely unrelated.
Sure.
I need to think of a good birthday present for my wife. So for all those of you who want to help me buy at Wendever something, please let me know what you think I should get her.
Yeah, suggestions. Drop them in the comment section.
Drop them in the comments.
I am a solo mom by choice, and it's the best choice I've ever made. Anonymous donor.
Awesome. Nothing wrong with that.
Is there a difference in success in FET immediately following a 3-month suppression versus a few months later following a 1-month booster?
Well, I mean, it depends on how many months later. But no, there shouldn't be a difference if it's reasonably short interval in between.
Hi, Dr. Kings.
Oh,
it's just
Dr. Kings. It's getting better and better. It's like
really is.
Now it's multiplying Dr. Tons.
Yeah. This is it. This is it.
Yeah.
AMH 0.27 grams per mil.
What?
Yep. That's what I have.
0.27 grams per mil?
Grams is what it says.
Okay.
But had 6 AFC. Okay. Will I be a better responder than anticipated? I forgot age 39.
I've never seen that conversion. AMH grams per mil. I got to put that one in here and see.
Hi from Great Britain.
That's not even a choice. Maybe she means nanograms per mil.
Maybe it omitted the N.
Do you mean nanograms per mil? Because 0.27 nanograms per mil is about 2 in our units, which is picomoles per liter. Yeah, 1.93. I mean, I would say that it's like you're going to anticipate that only a few of those 6 would grow, but you could stimulate them if you took all the right priming.
I liked seeing you there. I'm assuming at the Canadian show.
Yeah.
But I have a different perspective at the show. Have different perspectives at the show.
Oh. Okay.
Interesting.
Maybe they meant that they liked the fact that I was there, but they also liked the fact that they had Pratty and Tom.
Yeah, different perspectives.
Yeah.
They enjoyed the different
Yeah.
perspectives.
I do too. I mean, hey, listen, they put up a good argument. I can't say I agree with it. So here's what happened.
They have
said,
one condition for the show. This is very important because you're going to go in that direction. If a doc is ludicrous, you have to call them out. It's your responsibility.
I might leave that one to you, buddy.
I'll do it.
You can do it.
I will be the
can't do
king.
that.
Yeah.
So here's the thing, right? Like one of the comments that was made was wait, you know, because I was talking about immune and microbiome, and I mean, there's no question, immune and microbiome are important. But one of the comments was no. If you just have 3 euploid embryos, it's a 95% chance. It's actually 95.2, and they said it was over 90, but the number is 95.2. And that if you and they didn't mention it, but if you have 5 embryos, it's actually a 98% chance. That's with 0 adjunct therapy. No steroids, no intralipids, no immune, no microbiome, nothing. Okay. No extra testing, no extra treatments, 0. Just keep putting in, you know, embryo after embryo that's euploid with a, you know, standard hormone replacement therapy protocol. Here's the problem with that. Depending on how old you are, getting between 3 and 5 euploid embryos could be anywhere from easy to difficult to unattainable to you need to be a millionaire. So it's not fair, in my opinion, to use those studies to convince people that they should just keep going, because our goal should not be get 5 euploid embryos so you can make 1 live baby at a 98% chance. Those poor embryos, like each one of those should have a 98% chance. Why aren't we optimizing for people so that each embryo gets a 98% chance? That's my argument against that. I understand the science. I've known it forever. We've presented it on the show. But the problem is that's not a fair thing to say to someone. Like if you're 38, you really want me to tell you you need 5 euploid embryos? That's like 4 rounds of IVF. Who the hell has time or money or emotional stamina for that? It's brutal. It's like totally savage. So I don't think we should be doing that to people. I think we should be getting whatever we can get with some reasonable expectation of success, and then say to people, like, this is what you need to do to get the best chances you can get. Not, hey, just keep transferring till it works. That's not a fair approach. It's great for making me super rich because you're going to come for umpteen IVF cycles, but like I've destroyed you in the process. I don't want to do that. I don't care how wealthy I get. Like I'm not going to sleep at night knowing I ruined people. So that's the wrong approach, in my opinion. We should be optimizing, and we should always be struggling, fighting, plowing forward to actually get the highest success rate possible. And that's a great way to end the show. I'm going to end the show. So it's 9:05. Sorry if we didn't get to your questions. Make sure you message them to us. Happy to look. Please go on our social medias. Please help us go viral. That's how we get to grow and do more and reach more people and help more people. Tell all your friends. Lots of comments, lots of love. We'll see you next week. We will review, for all those of you suffering from diminished ovarian reserve, whether or not you are capable of making equivalent quality embryos to people that don't have diminished ovarian reserve. See you next